Good evening, everyone, and thank you for joining us tonight as we honor Alpha Kappa Alpha Sorority Incorporated Breast Cancer Awareness Impact Day. My name is Kenford Brown, and I'm the president of Alpha Kappa Alpha Sorority Incorporated Upsilon Epsilon Omega Chapter. And on behalf of our sorority leadership, I welcome you. Recognizing that breast cancer results in death for African American women at nearly double the rate of white women, Alpha Kappa Alpha members are observing Breast Cancer Awareness Day during nationally recognized Breast Cancer Awareness Month. Breast Cancer Awareness Day aims to raise awareness about the disease and raise funds for research into causes, diagnosis, prevention, treatment, and cure. We take time now to honor those who are breast cancer survivors and honor our loved ones who have transitioned due to complications with breast cancer. Tonight, we are hosting a conversation, and we sincerely thank Dr. Lisa Newman for joining us this evening to discuss early detection, treatment, and disparities prevention. Thank you all who are attending, who are joining in the conversation. Thank you for all who have planned this wonderful conversation, and we know it will be a critical discussion. So at this time, we will move along in our webinar. Again, thank you for joining us this evening.
Good evening. My name is Connie Folks, and I have the pleasure of reading the bio for Dr. Lisa Newman. Dr. Newman is a surgical oncologist with a practice dedicated to breast cancer management. In August 2018, she was appointed to oversee the breast program for the Weill Cornell Medicine New York Presbyterian Hospital Network, serving its Manhattan, Queens, and Brooklyn sites. Dr. Newman obtained her undergraduate and Master of Public Health degrees from Harvard University. She attended medical school and completed her general surgery residency training at State University of New York Downstate Medical Center in Brooklyn. She pursued fellowship training in surgical oncology at the MD Anderson Cancer Center from 1997 to 99, followed by joining the faculty as an assistant professor. She continues to hold an adjunct professorship with MD Anderson. Dr. Newman's primary research has focused on race, ethnicity, related variation in breast cancer risk and outcome, the evaluation and management of high-risk patients, broadened applications for neoadjuvant chemotherapy and special surgical techniques. Her extensive research related to disparities in breast cancer risk and outcome has been published in numerous peer-reviewed medical journals and was featured in CNN's documentary, Black in America 2. She has also been featured in the Breast Cancer Medical Expert for NBC's Today Show 2014, 2017, and 2019, as well as on CBS Nightly News in 2015. Dr. Newman maintains a very active community service record nationally and internationally. She oversees an international breast cancer research and training program involving a network of physicians and facilities in several countries such as Ghana, Mexico, and the Caribbean. She's been recognized for her work by Top Blacks in Healthcare, Oprah's Angels, and Top Doctors of America. Dr. Newman has also been awarded the coveted title of Komen Scholar and is a member of the Komen Scientific Advisory Board. Most recently, Dr. Newman has been appointed to multiple national and regional leadership positions. In October 2019, she was appointed second vice president-elect for the American College of Surgeons. Please join me in welcoming Dr. Lisa Newman.
Thank you so much, Connie. That was an incredibly kind introduction. I really appreciate that. So I am going to go into the share screen mode here. Okay, how's that? Are you guys seeing my screen now? Okay, all right. So So over the next few minutes, I will indeed be speaking with you about breast cancer, early detection and screening, treatment and disparities, and especially pertinent to the topic of disparities, I want to thank all of you who are on this Zoom meeting. It's just so beautiful and magnificent to see sorority sisters taking care of other sisters and spreading the word out about breast health awareness, which is so very important, especially for our African American community. Now, breast cancer is a very high risk, high burden disease in America among adult women. However, there are certain features that do identify some women that are at even higher risk compared to other women. The biggest risk factor that unfortunately we all have to be aware of is increasing age. And for all of us, no matter what our racial ethnic background and no matter where we live, as we get older, the likelihood of being diagnosed with a breast cancer increases. There are some clinical features that are relevant. And in particular, if you come from a family where there are multiple women with breast cancer, if you come from a family where there is a man with breast cancer, or if you have lots of relatives with ovarian cancer, those are all red flags that you might have some inherited hereditary predisposition for breast cancer. Menstrual history, in terms of looking at how old women are when they start having their period and how many pregnancies they've had and whether or not they were older when they went through menopause, those types of factors are important when we are looking at the breast cancer burden of populations of women. So when we're looking at countries and many thousands of women and trying to identify populations that have a higher or a lower breast cancer burden. But those menstrual features are not relevant when we are talking about an individual patient and her screening needs. Histopathologic features, on the other hand, are very important for individual patients. And if you've ever had a breast biopsy and were given the good news that the biopsy result was benign, that is absolutely good news, but it's also important that you find out the details of that biopsy report, because there are some benign patterns of fibrocystic changes that do identify basically overactive breast tissue, and they identify women that have a higher risk of getting breast cancer in the future. And those women might want to do extra screening of their breasts, such as MRI in addition to the mammogram, or they might choose to take special pills to lower their risk of getting breast cancer. There are important lifestyle risk factors to be aware of, especially in postmenopausal women. Obesity is a major risk factor for getting breast cancer. Also in postmenopausal women, using supplemental hormone pills, especially if they're used for several years, increases the risk of getting breast cancer. And excessive alcohol intake is a risk factor for breast cancer. Nonetheless, about 3/4 of the women that we diagnose breast cancer in don't have any of those identifiable risk factors. And so all of us, simply by virtue of being women, have to be aware of breast cancer risk factors and how to protect ourselves from the disease through early detection. Listed here are the main ways that we can be aware of changes in our breast and identify a breast cancer at an early stage. One is just self-awareness of any changes that develop in the breast. Also, making sure that your healthcare provider includes a good comprehensive breast exam every time you get that annual checkup. Screening mammography is the most important way to effectively detect a breast cancer at an early stage before it causes any symptoms. Screening mammography, we recommend for average risk American women to be initiated at age 40 and to continue every year thereafter following age 40. Now, I'm sure you've all heard that there is some controversy regarding screening mammography guidelines, but most of us as breast surgeons adhere to the guidelines that are endorsed by the National Comprehensive Cancer Network and the American Society of Breast Surgeons. You save the most lives from breast cancer if you get those mammograms every year starting at age 40. It's also important to remember, however, that screening mammography guidelines are intended for women that have a normal breast exam, where you're looking for a breast cancer before it forms a lump or any symptoms in the breast. If a woman does have a change in her breast exam, she has to go through a diagnostic workup and seek medical attention right away. It doesn't matter if she had a mammogram a month earlier that was normal. A new symptom is a sign to seek medical attention. Now, the value of screening for breast cancer is that it does indeed save lives. And getting those mammograms on a regular basis results in about a 20 to 30% lower risk of ever dying from breast cancer. Catching a breast cancer early with screening improves the availability of more treatment options, such as breast-saving surgery and being able to avoid a mastectomy for treatment of that cancer. If the woman does still need to undergo a mastectomy, she has better breast reconstruction options that she can pursue. Getting a breast cancer caught at an early stage reduces the likelihood that chemotherapy will need to come into the picture, and it also reduces the extent of any lymph node surgery that will be necessary. Lymph node surgery is the surgery that we do for the glands in the underarm area of a breast cancer patient. Catching that cancer early means less extensive surgery. So the next few slides are just showing you some examples of cancers caught on a screening mammogram. I hope you can see my cursor here, but the white spiculated lesion in the middle of this mammogram is an example of a cancer. Other breast cancers are caught as what we call microcalcifications on the screening mammogram. And microcalcifications kind of look like little grains of salt sprinkled on the mammogram. It takes the trained and expert eye of the breast radiologist to determine whether the pattern of those microcalcifications is such that a biopsy would be indicated. But screening mammography is an excellent way to catch a breast cancer at very, very early stages through the identification of microcalcifications that are suspicious in their pattern. Breast ultrasound is a wonderful adjunct to screening mammograms in evaluating lumps or densities in the breast. Sometimes an ultrasound will show that a lump in the breast is completely benign, such as what we're seeing on the left side of this slide, a simple cyst of the breast, which is just encapsulated fluid in the breast. And if you can document that a lump is a pure cyst with an ultrasound, you can be very confident that that's a benign lump. Sometimes we will even aspirate those cysts in order to make them go away. This on the right side of the slide, on the other hand, is a cancerous lesion of the breast identified by ultrasonography as an irregularly bordered lump in the breast. This is an example of how mammogram and ultrasound can be used in partnership. On the left of this slide, the patient has a density, just basically wider, thicker tissue in the breast in one part of the mammogram, and the ultrasound area looking at that spot is showing you this irregular marginated lesion, which did actually represent a cancer in the breast. Other modalities of breast cancer screening are important. Very commonly, we will rely upon 3D breast tomosynthesis, which is a very excellent way of evaluating dense breasts. Breast magnetic resonance imaging, or MRI, is a very useful supplement to screening mammograms, especially for women that have inherited susceptibility or predisposition for breast cancer. Whole breast ultrasound, as I mentioned before, can be very useful as a partner to the mammogram, especially in evaluating young women's breasts and very dense breasts. Molecular breast imaging is a investigational tool that is still under development, but it's an exciting novel technology. Now, it's important to bear in mind that none of these breast imaging technologies is perfect, and there are some cancerous lumps in the breast that might be quite obvious on plain old clinical examination, but they can be invisible on that screening mammogram. Mammograms are great, but they're not perfect. So all women, even if they are being compliant with those annual mammograms, all women do need to be aware of the danger signs of breast cancer, which include a new lump in the breast, a bloody nipple discharge, breast skin changes such as redness, inflammation, or swelling in the skin of the breast, eczema type of changes in the nipple areolar skin, and if you develop a new lump in the underarm area. Now, all of those danger signs can also be explained by completely benign, non-cancerous problems, but the important message is that if you do develop one of these danger signs, you have to seek medical attention so that you get the proper workup. It might mean having to have a biopsy, but you have to undergo that workup so that you know whether you're dealing with a cancerous problem or a non-cancerous problem. And if you don't believe that you're getting the right answers when you seek medical attention, please go out there and get another opinion. Now, it's also to emphasize that there are strategies to reduce our breast cancer risk. Nursing babies and lactation is an excellent way of lowering breast cancer risk. Making sure that we follow a healthy, balanced diet with lots of fresh fruits and vegetables and avoiding obesity is a good way to reduce breast cancer risk. Exercising regularly is an excellent way to reduce breast cancer risk. And as we alluded to before, minimizing alcohol intake will also lower breast cancer risk. Now, if a breast cancer does indeed end up being found through whatever screening modality or detection modality occurred, it is important to remember that the high majority of breast cancer patients will have a good outcome because we do have very effective treatments for breast cancer. Usually surgery will be an important component of that treatment for the breast cancer. The three principles of treating a newly diagnosed breast cancer are shown on this slide. You have to get rid of that cancerous lump. You also have to treat any microscopic breast cancer cells that might be hiding in the normal appearing breast tissue. So this is where women will have the choice of either undergoing mastectomy, which takes care of both of those principles in one fell swoop. And for women that do pursue mastectomy, we have great plastic surgeons who can do breast reconstruction for most patients right at the same time that the mastectomy is being performed. And the alternative to the mastectomy is when we perform a lumpectomy to get rid of the cancerous lump, and that's followed by radiation to kill any of the microscopic cancer cells hiding in the normal appearing breast tissue. And for most women, some surgery will also be necessary for the lymph nodes or the glands of the underarm, which represents one of the areas where a cancer can spread from the breast. And it also represents important information to help us determine more about the aggressiveness of the cancer. So now I'm going to switch gears and talk about breast cancer disparities, and in particular, focus on the breast cancer burden of African American women. Well, it is indeed true, tragically so, that breast cancer death rates are higher in African American women compared to white American women. And this is largely explained by socioeconomic differences because the higher poverty rates, the higher rates of lacking insurance, both of these problems in the African American community will lead to a more advanced stage distribution for breast cancer and the higher likelihood of incomplete treatment for the breast cancer. And this unfortunately results in higher death rates from breast cancer. However, we've known for many, many decades that socioeconomic factors are not the only factors explaining breast cancer disparities. And an example of the evidence behind this fact is shown here. Several years ago, I and some colleagues from the Harvard School of Public Health conducted a meta-analysis, which basically means that we pulled together all of the data in the medical literature looking at breast cancer survival in Black women compared to white women, and we looked at studies specifically that evaluated for socioeconomic status. And even after accounting for socioeconomic status, African American breast cancer patients have a nearly 30% higher death rate from breast cancer compared to white American breast cancer patients. Furthermore, there are several features that characterize the breast cancer burden of Black women compared to white women that can't be ascribed to socioeconomics. For example, we tend to be younger when a breast cancer is diagnosed. And up to 40% of Black breast cancer patients are diagnosed younger than the age of 50, compared to only 1/5 of white American breast cancer patients being diagnosed in this younger premenopausal age category. Also, African American women are more likely to get the biologically aggressive triple-negative breast cancers and high-grade tumors in the breast. There's also a higher incidence of a particularly aggressive form of breast cancer known as inflammatory breast cancer in African American women. And lastly, there's a higher incidence of male breast cancer in the African American compared to white American community. So because of all of these characteristics, we really do need to look at tumor biology and the genetics of the disease in trying to comprehensively understand breast cancer disparities. Now, what do I mean by this biologically aggressive form of the disease known as triple-negative breast cancers? Well, whenever we look at breast biopsy material that shows an invasive cancer, we always then have to look for 3 particular proteins or biomarkers on that cancer. The 3 markers are the estrogen receptor, the progesterone receptor, and HER2/neu. Cancers that are negative for those 3 markers are what we call the triple-negative breast cancers. And I'm showing you an example of biopsy material at the bottom of this slide for a triple-positive breast cancer that expresses all 3 of those markers, compared to a triple-negative cancer that is negative for all 3 of those markers. The triple-negative breast cancers are inherently more aggressive, and again, we do see them twice as common in African American breast cancer patients compared to white American breast cancer patients. Now, there's been an interesting phenomenon over the past several years where there's been a disproportionate increase in the incidence rates of breast cancer in African American women. And now the incidence of breast cancer is the same for African American compared to white American women, whereas it used to be that the incidence of breast cancer was actually somewhat lower for Black women compared to white women. So these rising incidence rates of breast cancer in Black women, coupled with the higher risk of the biologically aggressive triple-negative breast cancer, has resulted in a widening of the mortality gap between Black women and white women, such that death rates from breast cancer is now 40% higher in the Black community compared to the white female community. And this is where it's important to make a few more comments about screening mammography. Screening mammography is especially important in the African American community, and this we found very prominently in looking at our Henry Ford Health System patient population from metropolitan Detroit. And Detroit has a very large African American community. We therefore also had a very large triple-negative breast cancer patient population. We looked at our Henry Ford patient population and looked specifically at the triple-negative breast cancer patients to try to determine what were the features that describe triple-negative breast cancer patients that had a better outcome compared to others. Well, it did turn out that mammography screen detected triple-negative breast cancer was the most important factor in identifying a triple-negative breast cancer that had a better outcome. And this was especially prominent in the African American community. So again, screening mammography, incredibly, incredibly important in addressing and reducing disparities. Now, many of the primary care doctors out there are a little reluctant to recommend screening mammography for their patients younger than the age of 50 because the United States Preventive Services Task Force has been advocating that American women wait until they reach age 50 before they get started with those screening mammograms. That practice is incredibly dangerous when it comes to disparities because we as African American women are more likely to get breast cancer at younger ages, and we're more likely to get triple-negative breast cancers at all ages. And so all of us as ambassadors talking about breast health awareness have to guide our primary care provider colleagues to understand that even though the different professional societies may advocate for mammograms having to be initiated at different ages, they all advocate in favor of access availability of mammograms beginning at age 40. And President Obama, back when the Affordable Care Act was being sponsored, he issued a presidential proclamation that screening mammography would always be covered beginning at age 40. Now, this higher risk of triple negative and hormone receptor negative breast cancer among African American women is not something unique to the United States. And if you look at studies conducted in England, in Brazil, and even in Switzerland, those countries have also shown that their African ancestry populations have higher rates of triple negative disease and estrogen receptor negative cancers compared to their white ancestry, European ancestry patient populations. So this is the background motivation for the international studies that our group has been conducting. We've been partnering with different cancer treating facilities in different areas of Africa to try to determine whether there are some inherited features associated with African ancestry that predisposes for these aggressive forms of breast cancer. Here's just a photograph of two of the partners that I've been working with for many years. Dr. Bafour Awa is my oldest and most longest standing partner, and I've been working with him when we started this venture, focusing on the breast cancer burden of women from Ghana, which is located in Western Sub-Saharan Africa. And in Ghana, we've seen that about half of the breast cancers are triple negative tumors, and this is compared to about 1/4 of the breast cancers in African American women being triple negative, compared to only 15–16% of the cancers in white American women being triple negative. More recently, we've also been partnering with cancer treating facilities in Ethiopia, which is important to acknowledge that Ethiopia is located on the eastern coast of Africa. And here we see some interesting patterns. Again, about half of the Ghanaian breast cancers are triple negative, compared to only 15% of white American women having triple negative breast cancers. And interestingly, we see low frequencies of triple negative breast cancers in Ethiopian women at only 15%, similar to what we see in white American and European women. But the frequency of triple negative breast cancer in African American women is intermediate between what we see in Ghanaian women and what we see in white American women. So we explain these patterns by an area of research that we've termed as oncologic anthropology. And if you look at the background of shared African ancestry and the transatlantic slave trade, it makes sense that we would see similar patterns of triple negative breast cancer in African American women compared to what we see in Ghanaian women, because the transatlantic slave trade brought the ancestors of Western Sub-Saharan Africans, including Ghanaians, across the ocean to populate the Americas as slaves. And so as African Americans in contemporary era, we have a lot of shared ancestry with Ghanaians. However, the slave trade from East Africa was largely controlled by Arabic traders who brought the ancestors of contemporary Ethiopians and East Africans further eastward to populate the Mideast and Asia. So as African Americans, we do not have quite so much shared ancestry with East Africans and contemporary Ethiopians. So if there is something of a heritable nature associated with the risk of triple negative breast cancer, you would see it indeed in Western Sub-Saharan Africans, which is what we've been identifying as being the true heritable link associated with African ancestry. And we see it expressed more strongly in African Americans than we see in East Africans. So for the past several years, I've been partnering with this absolutely brilliant geneticist, Dr. Melissa Davis, who serves as the scientific director for our team and conducts a lot of our basic science research studies. And for most of Melissa's career, she's been an expert in a particular gene known as the Duffy gene. And the Duffy gene is important when we look at disparities because there is a particular variant, a particular pattern of the Duffy gene that is very closely linked to Western Sub-Saharan African ancestry. And you guys are all aware of the commercial products like 23andMe, Ancestry.com. All of these commercially available products are looking at particular genetic markers that are often called ancestry informative markers. And if you remove the DNA from saliva specimens, you can look at these different ancestry informative markers to give an individual that purchased these products a background picture of their ancestry. Well, there's a particular marker in the Duffy gene that is linked specifically to Western Sub-Saharan African ancestry, and so it's an ancestry informative marker. And we've been looking at the Duffy null ancestry informative marker to try to evaluate risk of high-risk triple-negative breast cancer when it comes to African ancestry populations. Most of the studies that have been conducted looking at genetic markers for triple-negative breast cancer have been performed in populations of patients that do not have African ancestry. And so these studies largely overlook the Duffy null marker, which is linked to Western Sub-Saharan African ancestry. So in our research, we've specifically been making sure that we bring the Duffy null marker into our studies so that we can learn more about African ancestry and risk of triple-negative disease. And cutting to the chase, what we have indeed found is that the Duffy null marker, which is a marker of Western Sub-Saharan African ancestry, is indeed an extremely powerful, strong predictor of having a triple-negative breast cancer compared to having a non-triple-negative breast cancer. And this pattern is still explained by this field of research that we call oncologic anthropology, because there's a very legitimate reason why the Duffy null variant is so closely linked to Western Sub-Saharan African ancestry, and it's related to the story of malaria in Africa. About 10 to 11,000 years ago, malaria became endemic in Western Sub-Saharan Africa because there were a lot of watery areas in that part of the continent that supported the mosquito life cycle. And the mosquito is, of course, the carrier of the malaria parasites. So because malaria is such an incredibly deadly disease, the human genome was under very strong selection pressure over the past millennia to try to acquire resistance against this deadly disease. And this didn't just occur in Africa. In European areas where the Mediterranean, as another watery area supporting the mosquito lifestyle, the Mediterranean is another area where malaria became endemic. And so in the Mediterranean area, there were particular genetic variants that also developed as a consequence of trying to confer resistance against the disease malaria. In Africa, the sickle cell trait is one variant that confers resistance to malaria, but because sickle cell is associated with other adverse health consequences, you don't see it quite as prominently as you see the Duffy null variant. The Duffy null variant, because of the way that it allows the Duffy protein to be expressed on red blood cells, is another way of becoming resistant to malaria, but it doesn't have quite as many adult health consequences, and therefore the Duffy null variant is expressed in almost all Western Sub-Saharan Africans in contemporary life. The Duffy null variant, through the transatlantic slave trade several hundred years ago, brought that Duffy null variant across the ocean, and about 2/3 to 3/4 of us as African Americans also carry that Duffy null variant. Because of the geography of East Africa, with a lot of mountainous areas that don't have the same watery areas that support the mosquito life cycle, the story of endemic malaria in East Africa is quite different. However, about 5,000, 6,000 years ago, something called the Bantu expansion occurred, where Western Sub-Saharan Africans migrated across the continent of Africa, and they brought that Duffy-Null variant with them. And so the East African populations do have some admixture with Western Sub-Saharan Africans, and so you do see some expression of that Duffy-Null variant in East Africa, but it's not seen to the same extent that you see it in Western Sub-Saharan Africa. So, oh, sorry, I left out a slide here, but it turns out that the Duffy-Null variant and its expression on red blood cells seems to be the key driver of this risk, this increased risk for triple-negative breast cancer, because the expression of that Duffy-Null, that Duffy protein on red blood cells also controls different circulating chemokines that are involved with breast cancer risk. And so our research has been focusing on identifying and tracking the connection between this Duffy-Null variant, which is linked to Western Sub-Saharan African ancestry, and the subsequent increase in risk for triple-negative breast cancer. So our international work has been very exciting because of these research opportunities, but it's also been very rewarding to us because it's also allowed us to invest in the healthcare of underserved populations in Africa. And we've been able to establish academic exchange programs with breast cancer conferences. We've been able to establish immunohistochemistry programs that support the pathology programs in Africa. And now we have been able to conduct a lot of the research that we've been doing in Africa and aligning it with the breast cancer research that we are conducting today in the very diverse patient populations of metropolitan New York. And whenever I talk about disparities, I always close by quoting these three survival rates of 60%, 43%, and 20%, which actually don't have anything to do with cancer outcomes, but these are the outcomes for the first class, second class, and third class passengers of the Titanic. And it's important to close by focusing on those survival rates, because even though it's key for breast cancer disparities to look at genetics and tumor biology, it's also critically important for us to underscore the fact that outcome from any health threat, including breast cancer, is going to be completely dependent on access to care. And just as the third class passengers of the Titanic did not have equal access to the lifeboats, it remains true today that our underrepresented communities, including African Americans, do not have equitable access to the healthcare system. And this point was brought out to tragic extent in looking at the COVID pandemic, where African Americans experienced twofold higher death rates from COVID compared to white Americans, largely because of access issues. And as so poignantly expressed by the Reverend Dr. Martin Luther King Jr., of all the forms of injustice, inequality in healthcare is the most shocking and inhumane. And so I'll close there by thanking everybody for their time and attention, and with the very important reminder that we all have to get out there and vote on November 3rd. So thanks everyone, and I'll stop sharing my screen here.
Thank you so much, Dr. Newman, for that very informative presentation. We're going to check in with Sora Latrice to see if we have any questions on Facebook Live. Are you on mute? We can't hear you.
I'm sorry. At this time, we do not have any questions on Facebook Live. However, I do have one question in the chat. So
okay, go ahead.
The question that is being asked is, for women younger than 40 with family history of paternal aunts diagnosed with breast cancer in their 50s, would you recommend a screening for a mammogram screening right now?
Okay, yeah, so I definitely recommend screening mammography starting at age 40 and continuing those mammograms every year. With strong family history, multiple relatives with breast cancer, it's important to get evaluated for genetic counseling and genetic testing. And if the genetic testing shows that there is some documented heritable predisposition for breast cancer, such as a BRCA1 or BRCA2 mutation, then you might need to start getting those mammograms at younger ages. The rule of thumb that we use is that if you have relatives that have been diagnosed with breast cancer at younger ages, you should start getting those mammograms 5 to 10 years younger than the youngest age of breast cancer diagnosis. So, okay, I see another question about the difference between BRCA1 and BRCA2. So BRCA genes are genes that everybody has, but there are certain patterns in the BRCA genes, and there are two of them, BRCA1 and BRCA2, that there are specific patterns in these BRCA genes that confer a higher risk of getting breast cancer. So if we undergo genetic testing, which can either be done as a blood test or a saliva test, when we're looking for breast cancer increased risk, we typically focus on looking at those BRCA genes because those are the most common genes associated with breast cancer risk when a mutation is identified in those genes. The BRCA1 and 2 genes are also associated with particular ethnic predisposition and racial predisposition. So there are mutations called founder mutations that are very common in Ashkenazi Jewish people, and Ashkenazi Jewish people have to be especially vigilant about looking at genetic testing needs. I see a question about getting a mammogram before the age of 40. This will be recommended if you have relatives that were diagnosed with breast cancer at the age of 40 or even younger. And if you have a new lump in the breast, but you're younger than the age of 40, then yes, getting a mammogram and usually getting an ultrasound in addition to that mammogram will be important, even if you are younger than the age of 40. There's a question about breast density. Breast density is really related to how the mammogram looks. And if you have dense breasts on the mammogram, that is indeed a risk factor for future breast cancer development. And very dense breasts on the mammogram is an indication that supplemental evaluations like ultrasound will be important in trying to interpret that mammogram. There's a question about the African diaspora looking at the Caribbean. Yeah, great question. And there have actually been founder mutations identified in the BRCA genes that are specifically linked to Caribbean ancestry. And so again, if you have a strong family history of breast cancer, get that genetic testing done. It might be that you have one of these founder mutations in the BRCA genes that are linked to Caribbean ancestry. Question about motivating our dads, husbands, and sons to take breast cancer prevention seriously. Great question. Male breast cancer is twice as common in African American men compared to white American men. Now, it's true that breast cancer is rare. It's very uncommon in men regardless of racial ethnic identity, but male breast cancer is twice as common in Black men compared to white men. So if you have a new lump in the breast and you're a man, you have to get it checked out. And African American men should be more vigilant about their breast health. Oh, I see another great question. What's the likelihood of getting breast cancer if you don't have it by age 65? The risk of breast cancer continues to increase after 65, after 70, after 80. The older we get, the more likely it is that we will get a breast cancer. What's involved with genetic testing and how is the test performed? Great question. When we do perform genetic testing, we need to have a specimen that we can extract DNA from. And the best way to get DNA is from either a saliva specimen or a swab from the cheek or from a blood test. And that's why with the 23andMe genetic testing, they often they will just send you a special vial that you spit into, and then you put the cap on the vial, you send it back. And when the 23andMe or whatever company you're working with, when that company receives that vial back, they extract the DNA from that saliva specimen. I think I saw something in the chat room about neurologic problems like a stroke that can make it difficult to raise the arm. Yeah, that is definitely a disability that has to be taken into account when dealing with screening mammograms or when dealing with radiation for a known breast cancer diagnosis. In terms of screening mammograms, the technician has to work very carefully with the patient to make sure that any neurologic disability is accommodated. If the disability is making it excessively difficult to get that mammogram performed, this is where things like whole breast ultrasound may come into the picture, or even breast MRI. Whole breast ultrasound would probably be the best next step as an alternative to the mammogram if the mammogram for technical reasons cannot be performed.
So Dr. Newman, we have 3 questions from Facebook that I'd like to present at this time.
Okay.
So the first question is, are there any recommendations for preventing fibrocystic breasts?
Oh yeah, great question. Now, I do want to preface my comments by saying that fibrocystic breasts are completely normal, and fibrocystic densities, basically just having some degree of lumpy bumpiness in the breast, is absolutely normal for all women. The breast is comprised of a lot of different tissue types. We have fatty tissue in the breast. We have glandular fibrous tissue in the breast. We have blood vessels in the breast. And all of these different tissue types are subjected to the normal cyclic changes of hormones, causing those different tissue types to grow at different rates and to be more or less prominent at different times in our menstrual cycle and at different times in our life phase. So older women, postmenopausal women, tend to have more fatty tissue in the breast. Younger women tend to have more dense fibrous tissue in the breast. And these different tissue types account for the different lumpy bumpiness. It can make a breast exam more challenging, which is why we do have to rely upon breast imaging in addition to the clinical breast exam to evaluate whether a particular lumpy area in the breast represents a dangerous lump versus the normal breast tissue. One of the more challenging aspects of my job as a breast surgeon is when patients come to me complaining of the breast pains that are associated with some fibrocystic changes. Now, breast pain in and of itself is not necessarily a danger sign of breast cancer. It usually is a sign of fibrocystic changes in the breast. But if a woman notices a change in the symptoms in her breast, a change in the pattern of her breast pain, then just seek medical attention and get that clinical breast exam to sort out whether or not there's something worrisome going on. But in and of itself, breast pain is generally not a danger sign of breast cancer. It also does not mean that a breast cancer isn't present in the breast. So if there's a change in the symptoms of the breast, seek medical attention to sort out the cause and the explanation.
The next question was, is genetic testing typically covered under insurance?
It will be covered by most insurance plans, but not all of them. And some women will prefer to not have their insurance plan be involved with the genetic testing because some women simply don't want to take the chance of any information being available to their insurance company regarding their genetic testing results. Those are personal decisions to make. When a woman does decide that she wants to pursue genetic testing, it's important for her to be aware of some of the issues related to privacy. There is federal law that protects against genetic discrimination in the workplace when it comes to employment or routine medical health insurance policies, so that you shouldn't be discriminated against if you are found to have genetic predisposition, hereditary predisposition for cancer. But those federal laws do not protect against life insurance plans and certain types of long-term disability coverage. So it's important to be aware of these limitations in the federal law. And if you are going to pursue genetic testing, make sure that you have any health insurance coverage, any life insurance plans, get all of those things wrapped up before you actually get that blood test sent off or that saliva specimen sent off for the genetic test results.
Thank you for your response, Dr. Newman. We have another question from Facebook, and the question asks, I know firsthand that in our community, we often find it taboo to discuss cancer. Some people in our families feel some kind of way about sharing their diagnosis. What do you say to relatives who have been diagnosed with some sort of cancer, but is just not in the headspace to educate extended family members?
Yeah, that's a great question. Thank you. I think that it is important for us to speak frankly with our relatives in trying to get information and in trying to get our relatives to be more forthcoming, because this information can be empowering and it can affect how we take care of ourselves. If it does turn out that there are multiple relatives with breast cancer, ovarian cancer, colorectal cancer, prostate cancer, this can affect how we get screened for these various types of cancers, and the information can be life-saving. If that family history information does indeed point towards some hereditary predisposition for cancer, it might make those relatives want to avail themselves of special prevention or risk-reducing technologies. There are medications that can reduce breast cancer risk. Some women will want to pursue prevention surgery, such as prophylactic mastectomy, to try to reduce breast cancer risk. These types of information don't tell a woman that she has to pursue these different risk-reducing strategies, but at least she can become aware of those strategies being available as options. Colonoscopy can be a very important way of looking for polyps in the colon and looking for early stages of colorectal cancer. Families that are found to have inherited predisposition for colorectal cancer might need to start undergoing colonoscopy at younger ages. And identifying a polyp in the colon can be a great strategy of preventing colorectal cancer. So that family tree information can indeed be life-saving.
Hi, Dr. Newman. Thank you so much for the answer to that question. There's another question from the chat. You mentioned that drinking alcohol can be a cause of breast cancer. Should alcohol be completely eliminated from our diet? And does this include wine as well?
Yeah. So great question. It is true that zero alcohol intake is associated with the lowest likelihood of getting breast cancer when we talk about the trajectory of amounts of alcohol intake. And it's a linear correlation between amount of alcohol intake and rising risk of breast cancer. But that does also have to be balanced against some of the cardiovascular benefits of low quantities of alcohol, especially things like red wine. So my best recommendation is that it's all about moderation and balance in life. And I don't think that every woman has to completely eliminate alcohol from her intake, but you want to be balanced. You don't want to have alcohol in excess.
Correct. So the next question is, what poor nutritional habits increase the risk?
I'm sorry, what nutrition?
What poor nutritional habits increase the risk?
Oh, okay, great. Thank you. So in general, higher fat diets will increase breast cancer risk, and just too many calories because of the link to obesity will increase breast cancer risk. And for having a diet that's abundant in fresh fruits and vegetables is a good way to lower breast cancer risk. And exercise, I can't emphasize strongly enough, regular exercise is a very good way to lower breast cancer risk.
Okay, thank you. So are regular mammograms just as effective as 3D mammograms? I know some insurances may not cover 3D mammograms.
Yeah, great question. Now, most mammography programs will be offering 3D mammography, and they will really strongly push 3D mammography if the woman is found to have dense breasts on the conventional mammogram. So make sure that your radiologist is explicit in describing the appearance of your breast density, because that might facilitate getting appropriate health insurance coverage for that 3D mammogram.
There's another question that says, are there any foods, besides tumors, besides having tumors, what are the warning signs of breast cancer?
So I'm glad they asked that question, because I love emphasizing the danger signs of breast cancer. So besides noticing a new lump in the breast, other things that a woman should be aware of, or a man should be aware of, would be a bloody nipple discharge, certain skin changes in the breast, such as inflamed skin or swelling in the skin of the breast, and changes in the nipple areolar skin, such as eczematoid appearing skin in the nipple areolar region. That can also be a danger sign of a particular pattern of breast cancer called Paget's disease of the nipple. When we look for the swelling and the redness in the skin of the breast, that can be a danger sign of a particular pattern of breast cancer called inflammatory breast cancer. Oh, I did notice a question in the chat room about the maternal side of the family. And here I do want to emphasize that in looking at the family tree, you have to look at the maternal side and the paternal side. These hereditary susceptibility genetic mutations can be passed along from your mom or from your dad. So you do want to look at both sides of the family when evaluating the family tree.
Thank you so much, Dr. Newman. Unfortunately, we have run out of time, so I'm going to turn it over to our chapter vice president, Dr. Nakia Showell, for closing remarks.
Thank you,
everybody.
Thank you so much, Dr. Newman, and I'm so sorry that we ran out of time. We had a lot of great engaging questions. Thank you for your expertise, discussing a wonderful overview of breast cancer, and particularly what we should be doing as Black women to advocate for early detection and screening programs and risk factors that we need to think about and being mindful of moving forward. So thank you so much for investing your time this evening. On behalf of the Upsilon Epsilon Omega chapter, you will receive this wonderful token of our appreciation, if you can see that.
Thank you.
This evening in the mail. And again, we really want to thank you so much. I want to thank the event leads for this evening and our wonderful moderators, Ms. Vinay, Ms. Sutherland, Mrs. Folks, our women's healthcare and wellness leads, Mrs. Kelly and Mrs. Petway, and all our committee who's working behind the scenes to make this an exciting event. And to our participants, thank you for a great engaging discussion. We had a very robust discussion and several questions. And our discussion and dialogue on health and program building does not stop here. We want to remind everyone to follow us on our website and our social media platforms and remind you that we do have some upcoming programming. On October 8th, we will be kicking off our Dave Ramsey's Financial Peace University, which is an awesome financial wellness course, 9 weeks, and we do intend to support 3 families for this course for free. And that's going to be a 9-week course starting on Thursday. And then we also have an opportunity to support our programs and scholarships through a virtual auction that starts on October 9th through the 12th, and information is there. So again, thank you so much for your time, Dr. Newman, this evening. This was a wonderful discussion and presentation. And thank you to everyone who was able to join tonight's webinar. And it will be recorded and on our YouTube page if you want to view it later. Thank you so much and have a great evening.
Thank you. It's been an honor. Appreciate it.